try to talk about the criteria for Meniere disease based on the criteria from 2015. It's not the most updated, but it gives you an idea. So Meniere disease also it should be idiopathic, but sometimes let's call it idiopathic and related to endolymphatic hydrops. So the clinical manifestation of Meniere, which is important because Meniere is usually a clinical diagnosed disease, also used audiometry, but you see it's mainly based on the clinical manifestation of the patient. So the clinical manifestation of Meniere is vertigo that episodical, attacks of vertigo, hearing loss, and what is called fullness, which can present with tinnitus and earfulness. And sometimes those patients, they have Tullio phenomena. Now Tullio is not very specific because they not must have it, and other pathologies, for example supraclavicular canal dehiscence, can also present with Tullio phenomena. So this is the clinical manifestation. The patient who comes with episodic vertigo, and though in those episodes he also feels tinnitus and sensorineural hearing loss and fullness, and those attacks usually from 20 minutes to 24 hours, and it's important because it's part of the clinical diagnostic criteria. So this is the clinical manifestation. There is not too much laboratory manifestation, not too much laboratory findings, including imaging, not too much. There are some subtle things that you may find. The vestibular aqueduct is narrowed and things like this, but it's not very specific. Not imaging, not laboratory tests, no genetic tests. There is no really good laboratory imaging clue for Meniere disease. Now the criteria is separated to definite Meniere and probable Meniere. Now the criteria for definite Meniere is at least 2 episodes of vertigo that last between 20 to 12 hours, and there should be, before, during, or after the episode, a sensorineural hearing loss in the audiometry. Now note that this sensorineural hearing loss is in the low and mid frequencies, which is not very common because sensorineural hearing loss usually comes in the high frequencies in the audiometry, and here sensorineural hearing loss is in the low and mid frequencies. Usually the conductive hearing loss can cause low frequency hearing loss, but here we're talking about sensorineural hearing loss with low mid frequency hearing loss. So this is special for Meniere, quite special for Meniere. Another criteria is the fluctuating hour symptoms, which can present with tinnitus, earfulness, and this is mainly. Now another the last thing for definitive is that it should not be explained by other pathology. Namely, there is no other pathology that can explain the symptoms, the manifestation, no other vestibular cause for this, no, I don't know, vestibular migraine or vestibular neuritis, or I don't know what. No other explanation for the manifestation of the patient. Now, when we're talking about probable Meniere, it's quite similar, but in the criteria, instead of 20 to 12 hours each vertigo, each attack of Meniere, we're talking about 20 minutes to 24 hours. And there is no criteria of audiometry. We don't need the audiometry to diagnose probable Meniere. So the other things are the same. You need at least 2 attacks, you need fluctuating hour symptoms, and you need not other explanation for probable Meniere. And of course, again, you don't need the audiometry for probable Meniere. For definite Meniere, you do need that. And it's very important distinction between probable and definite Meniere. So this is about Meniere disease criteria. This idiopathic endolymphatic hydrops based disease, and That's it. This is from 2015, so it's maybe not the most updated criteria, but this gives you the idea on how to diagnose meniere disease. That again, it's mainly on the clinical and audiometrical, but no other laboratory or imaging. There is a little bit imaging clues, but no, not diagnosis for meniere disease. Thank you very much, and this was about the diagnosis and criteria for meniere.